Welcome to the first session at Health Impact. You know, there's been a lot of discussion about how heroic our frontline workers have been. We talk a lot about them as if, you know, they've been doing something new, like they haven't been doing all of the same work before. And of course, some of it is new in the sense that the frontline workers are being asked to do things in a much more dangerous environment. But what I'm very interested in is, what are we doing to help understand what they actually need beyond the platitudes of being called heroes? Typically, you treat your heroes really well. You don't keep PPE from them. You don't keep supplies that they need. You don't tell them not to wear masks because your patients might be scared of them wearing masks. I mean, all the silly stuff that we've heard over the last few months. And the reason why we started with this initial conversation with Wendy here, and she's going to be introducing herself in a minute, is because we're very interested in trying to figure out what are the moral hazards that are taking place right now, especially on the care provider side. And so that's really why I'm really excited to kick off our initial talk here with a keynote from Dr. Wendy Dean, who's a psychiatrist, president, and co-founder at the Moral Injury of Healthcare. And what does that mean? Wendy, tell us a little bit about that, and then we'll kick off and have your keynote, and then I'll come back and ask you some questions about that.
Sure. So the Moral Injury of Healthcare is a nonprofit that co-founder Simon Talbot and I set up about 2 years ago to address the crisis of distress in clinicians across the healthcare field.
Great. And you've got a very special lens on this, being a psychiatrist, of course. And so that sounds great. So I'll let you go ahead and do your keynote presentation to us, and then we'll come back and with a little Q&A.
I'd like to thank the organizers at HealthIMPACT for inviting me into this conversation, because getting from resilience to radical change is critical in healthcare, and it starts with a conversation. So I'm looking forward to this one. Over the past 4 months, I have listened to providers across the country as they have negotiated and navigated their way through various levels of the pandemic response. In May, I heard from a clinician, an emergency room clinician in New York, who said that she had watched the pandemic come through Brooklyn and devastate the Black and brown communities that she lives with, that she works with, that she cares deeply about. And the fact that the health inequities that she has been fighting against for the past decade caused them to take this virus really, it took an inordinate toll on them, was breaking her, as she put it. In South Carolina a month ago, I heard from an emergency room doctor who said she was struggling with her infectious control department, who wasn't allowing that emergency room to make the changes that they needed to in order to take the best care of their patients, minimize their risk to potential viral transmission as their cases were surging. And then I heard from a colleague in Boston who said just a week ago, what happened? What happened? Did we not learn from New York and Seattle and Italy and China? I also heard a talk yesterday by Gerardo Reyes from the Coalition of Immokalee Workers. And what he said in likening the challenges of other essential workers, like those who are out making sure that we have food, what he said was, clapping for healthcare providers at 7 p.m. every night is wonderful, but it's not enough. They still need PPE. And he is absolutely right. We still need PPE. We need ventilators. We need additional staff. And calling healthcare workers heroes makes people think that we can do anything, that we can fix anything. And it also makes them think that we're invincible. But our real superpower as healthcare workers is our humanness, our ability to connect on a very human level. And in order to do that, we need to be able to take off our capes. So the pandemic that made healthcare workers heroes hit a system that was already in a crisis of distress. In 2019, 50% of clinicians surveyed acknowledged at least one symptom of distress. Half of them said that they were dissatisfied with the resources and efficiency of their healthcare environment, and a third of them were challenged by the flexibility and control that they had at work. And as clinicians are increasingly pulled away from their clinical concerns to attend to the business concerns of healthcare, we're running into more and more challenges. So we're asked to attend to quality metrics, to make sure that we're meeting productivity quotas. We're being asked to attend to the electronic medical record while the patient is in the room, which is distracting. We're required to keep our patient satisfaction scores high, all in the context of reduced staff with less autonomy and latitude than we are often comfortable with, all in an effort to control costs. But the reality is that we're having minimal impact on cost savings. So costs continue to go up. And in US healthcare, it's anathema to have a conversation about either allocation of scarce resources. That sounds an awful lot like rationing, and that is not where we want to go with our conversations. So instead, we talk about how to do the same amount of care or more care with less. We've cut staffing to the bone. We manage the return on investment for every square inch of healthcare space. And we rely on just-in-time delivery of our supplies in order to keep those stockpiles from hitting our balance sheet at the end of every month. That impacted day-to-day operations in a non-pandemic world. But when the pandemic is added to those concerns, that staff, stuff, and space that we're concerned about, when those are constrained in the context of a global pandemic, that has the potential to have catastrophic consequences. It has also left a lot of clinicians feeling like their hands are tied, like they know what their patients need, but they can't get it for them. So they know that the human thing to do for their patients is to put on PPE and go in and comfort them as they die. But if they do that, they're not protecting themselves because they're not conserving PPE that they're going to need down the road or that their colleague is going to need down the road. And that's a very painful double bind to be in. So it's no wonder that we're seeing levels of distress that are so high. And as I mentioned earlier, 50% of clinicians last year acknowledged at least one symptom of burnout, which is how we've characterized this challenge for the past 10 years. Burnout is a constellation of exhaustion, ineffectiveness, or lack of accomplishment, and cynicism or depersonalization, detaching from our patients. Healthcare administrators are concerned about this challenge because it presents a financial difficulty. It costs between $500,000 and $1 million to replace each physician who leaves the system. It costs about $70,000 to replace each nurse, and it leaves 90,000 patients every year looking for a new clinician. At the same time, there are very, very personal costs to this. The suicide rate for physicians is nearly twice that of the rate of suicide in service members that caused alarm in military leadership a couple of years ago and drove well-meaning, well-intentioned folks in the general public to be doing 22 push-ups a day. The healthcare system has not responded in the same way to this crisis of clinician burnout. The National Academy of Medicine in the fall did a comprehensive review of all of the assessment and interventions that we have tried to do to address the crisis of burnout over the past decade. And their conclusion was that they could not identify a series of interventions that consistently addressed the challenge of burnout. So when I think about that, I think we've had a public health crisis in the clinician community for the past 10 years, and we haven't been able to make meaningful impact into that crisis. Why is that? As a good clinician, I would think there are two ways to approach that. Either change our treatments, which we have tried multiple times over the past decade, none of which have had a profound impact. And the other way we can approach it is to reassess whether or not we have the right diagnosis. And so that was the approach that Simon Talbot and I took 2 years ago. He's a clinician at Brigham and Women's in Boston. He's a surgeon there. And we looked at what our colleagues had been telling us all across the country, that in fact, yes, they were feeling distressed, but that burnout wasn't really resonating with what their experience was. They were still deeply committed to the work of medicine. They were committed to their patients. They were very connected to them. They knew that they were signing up for long hours and witnessing difficult conditions. What they were struggling with was how they were being asked to work. So we proposed a new concept, one that we borrowed from the military that has been used to describe the distress that some service members feel after witnessing or engaging in egregious acts in the context of combat. And this is moral injury, perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. And in healthcare, those deeply held moral beliefs are the oaths that we took to put our patients first. And as we are being increasingly asked to attend not to what our patients need, but to the business constructs of healthcare, the complex allegiances that we have now to ourselves, to our patients, to our employers, are causing us increasingly to be distressed and pulled away from our core values. And it's causing a collapse of that powerful resilience that the burnout researchers have acknowledged. Healthcare administrative leadership knows that there are challenges. They know that their workforce is struggling, and that's confirmed from repeated surveys that are done over and over again. But they're challenged knowing how to best treat this. And so they've turned to other industries to learn how they address burnout. And they're inundated with a lot of turnkey programs that are meant to come in, and they promise to make meaningful changes in how people experience their work environment. And so these programs typically recommend things like yoga, mindfulness, meditation, to make sure that we exercise regularly, that we eat well, that we spend downtime, quality time with family and friends to make sure we bolster our resilience. And none of these are inherently wrong. They are all part of maintaining a high performance machine. But they also are ineffective at changing the drivers of moral injury or burnout that are at the heart of what our struggles are. In addition, most physicians already know that these are very useful for managing a high tempo, high stress environment. And burnout experts agree. There was a paper that came out 2 weeks ago that acknowledged that physicians have significantly higher resilience than the general public. And unfortunately, that even tremendous resilience does not protect against burnout. So how do we bring change? Bringing change can't happen from just the individual level. We've relied for a long time on the resilience and resourcefulness of individuals in our healthcare systems to make up for the gaps in health inequities, in the resources that we bring to the healthcare system, and in the planning and preparedness challenges that we have. So while it's necessary to support individuals, it is necessary but insufficient. We also need to look at what are the systems issues that bring to bear on individual responses and bring challenge to the healthcare system. And here there are tremendous opportunities in the pandemic. As much as I hate to say that, and it sounds trite, that there are silver linings in the pandemic, I think it's critical for us to look at what the lessons are that we're learning that will be useful going forward. And one of them is that this pandemic made healthcare very personal to everyone. the threat of serious illness made people pay close attention to how well the healthcare system was working, because we're all individualist creatures. So they wanted to know, is it going to be ready? Is it going to be there for me if I need it? And that really helped to highlight some of what's working well in healthcare and some of what needs to be improved. The pandemic also highlighted the gaps and vulnerabilities in healthcare as the system was stressed. And finally, there was an opportunity for those who weren't on the front lines, who were on the sidelines because elective procedures were shut down temporarily. There was the opportunity to reflect, as I said, on what's working well in healthcare. How might we change it? How might we be able to pick up and move on from here? And there were also opportunities because some of the regulations and restrictions and requirements in healthcare were relaxed to make operations easier during the pandemic. We may have the chance to look at those and say, do we want to pick those up again? Is there utility in picking them up again? Or do we leave them behind as we move forward? And finally, the other opportunity that we saw is our profound ability to adapt and to change in an instant when we need to. We were able to make big changes very fast with the appropriate amount, the appropriate motivations. So as we start thinking about how to move forward from resilience to radical change, there are a couple of assumptions that I think are really important. The first is that there is no knight in shining armor that's going to come and save us. I would love to say that that's true, but this is something that needs to come from all of us who are interested in the system, still committed to it, and want it to be better. It is also not useful to view this as an us versus them. It's not two factions pitted against each other. We're all working in the same system. And so finding ways to build bridges in understanding between administration and clinicians, between nurses and physicians, between all of the healthcare licensees is critical. It is also not going to happen fast. We need to make sure that we are in this for the long haul, because this is a marathon, not a sprint. One of the things that the pandemic has shown us is that leadership that stands with us, shoulder to shoulder, that walks in the trenches with us, that asks what we need to be successful every day, and then does their level best to get that for us, that's the kind of leadership that we will stand behind and walk through anything with. It's critical that we recognize that kind of leadership and foster it. We also need clinician leaders who are the player coaches, who know what the glitches in the EMR, what the impact they have, because those clinicians are practicing every day. They are engaging with that EMR. And so they can speak to it with other folks they're asking to change it with a level of granularity and expertise that a non-clinician might not have, or a non-practicing clinician might not have. We also need those player coaches to remain committed to their patient advocacy role and to their clinician workforce advocacy role. We need them to have the mindset of breaking down barriers, not explaining why they're there. And we also, in this broader conversation, I would hope that we can anchor that conversation in an exploration of what our common set of values are. What is important to our patients? What's important to clinicians in the patient-clinician encounter? What's important to our healthcare organizations? And how can we renegotiate that covenant of care between clinicians, patients, and organizations so that we have common goals and we can relieve some of the tension that is currently in our institutions? I also really want to recognize that we are all still in the midst of two separate storms. We're in the midst of the chronic storm of clinician distress, on which the pandemic was overlaid, an acute stressor. As we get some time and some distance on the pandemic surges and some of the challenges in healthcare, what we need to do and where we need to go may get clearer, and our needs may evolve. But I also think it's going to take a long time and many tellings for us to get to the point where we really understand what our healthcare needs are and what our system should look like. Einstein said one of his rules of work was, in the middle of difficulty lies opportunity. And I'm a tremendous believer that that is the case for this pandemic. We have seen the vulnerabilities in the healthcare system. We've had the opportunity to take a pause and to think about what we want to bring forward and what we can leave behind. And I think one of the real opportunities we have right now is to erase all of our preconceived notions about what healthcare should be and to start thinking about what it could be. So there's no clearly drawn roadmap that gets us to where we want to go. We know, I think a lot of us know what the kind of interactions are that we hope to have. And so what I hope we can do is to start orienteering with our moral compass as our guide and patient care, excellent patient care as our true north. Thank you very much. And if you want to join us, this is where you can find us.
That was great, Wendy. Thanks so much for getting this kicked off. I mean, we couldn't have had a better start to Health Impact. The team and I really are focused on trying to figure out how to make sure that the lives of the care providers get easier and easier. And this was a terrific reminder for us on how to do that. That's a perfect way of concluding your keynote here, and really appreciate you doing this. And what we'll do is go ahead and open up for questions from the audience right now, if any, and take it from there. Then again, thank you very much, Dr. Wendy Dean. Sorry we don't have any applause meters to do this, but there's going to be a lot of people applauding.
I hear it.